Thank you very much for inviting me here from Pakistan. I'm delighted to be here. This is my first time in Bangladesh. The previous two speakers have alluded to de-escalation therapies as far as radiation is concerned and surgery is concerned. Our job as medical oncologists is to balance the act of escalation and de-escalation, and we struggle all the time in a few patients where we don't know what would be the right treatment for the right patient at the right time. And I will go through data which will then help us and help you decide what is the right treatment for your patient. In 2024, the majority of the patients with early breast cancer will receive some form of systemic therapy, be that hormonal therapy, chemotherapy, or targeted therapy. And the composition and the duration of the treatment will depend on what is the clinical subtype of the patient, whether this is hormone receptor positive, TNBC, or HER2 positive. What are the clinical pathological risk factors which are going to impart the increased risk of recurrence in this patient? In patients who have neoadjuvant therapy and who have residual disease, what data should be using to implement further adjuvant therapy and the genomic assays which help us in decision making in hormone positive breast cancer. Now we have evolved from adjuvant therapy to neoadjuvant therapy in early breast cancers as far as the HER2 positive and the triple negative are concerned. So in the hormone receptor positive, which forms about 2/3 of our patients in a clinical practice, the question is this patient candidate for chemotherapy or not? What should I be doing for the young hormone positive? Should I be offering ovarian function suppression or ablation? What is the optimal duration of endocrine therapy, and should I be adding CDK4/6 inhibitors to the patients and PARP inhibitors in the adjuvant setting? So there is an unmet need which we feel remains in hormone receptor positive, as we know very well that about, let me check that pointer. So about 27 to 37% of the patients in the early breast cancer stage 2 will have a recurrence, and about 46 to 57% of the stage 3 patients will have a recurrence. And how do we determine the recurrence? Do we use the clinical pathological factors in these patients? We know there are patients who will have an early relapse, and then there are patients who will have a late relapse. What do we do? Do we do systemic therapy, chemotherapy for the early relapses, and then continue them on hormonal therapy and add something else to prevent the late recurrences? As we know very well that patients who have distant recurrences, it is a factor of how many lymph nodes are involved. So the larger the number of lymph nodes involved, the greater the chance that they will have a recurrence. So nodal disease, the nodal burden is a very important determinant factor in our selection of adjuvant therapy in the patients. And as we can see very well that patients, even if there are small tumors such as T1 tumors, the ones who have nodal involvement tend to have a higher recurrence. And of course, as we go up on the size of the tumor, the importance of the lymph nodal involvement becomes all the more important. So the goal is to identify which patients with high-risk disease and to spare the ones who have low-risk disease from chemotherapy, and how do we identify them? So the routine clinical pathological factors such as the grade of the patients, the age of the patient, the menopausal status of the patient, the presence of LVI, PNI, and the number of lymph nodes, and the extent of the hormone receptor positivity and the Ki-67 is something that we use in our daily practices. Unfortunately, we do not have in our routine practices, we do not have the luxury of the intrinsic classification of the tumor, because we know very well in the patients who are hormone receptor positive, there is a luminal A entity and there is a luminal B entity. The luminal A entity is the one which is mostly hormone sensitive, and these patients can be spared the effects of chemotherapy, whereas the luminal B are the ones which are more chemosensitive and require chemotherapy. So we rely a lot on the multi-gene assays, which is something which may not be feasible in low-income countries, but nonetheless, it is important to be aware of these. And there is the 21-gene assay, which has been approved and validated, which is the Oncotype DX assay. And then we have the 70-gene MammaPrint assay, which is used in UK and Europe. So these genes are a group of genes which will identify the behavior of the patients, and it also predict the response to treatment. Now this is a chart that is a combination of the Taylor X and the RX Ponder trial. Once you have the recurrence score on the Oncotype DX assay, which is anywhere from 0 to more than 25, and there are subcategories within these recurrence scores. So if you take the easiest part in this, which is the postmenopausal patient, the ones who are less than 25, whether they are node negative or they are node positive, they do not require chemotherapy. So postmenopausal spare them from chemotherapy if they're hormone positive and they have a recurrence score which is less than 25. Whereas premenopausal, it becomes a little complicated. So anybody who is node positive, 1 to 3 lymph nodes, and who are 11 to 25 and beyond will require chemotherapy. The ones who are node negative and premenopausal and who have a score of less than 15 can be spared chemotherapy. The discussion and the confusion starts in the 16 to 25 range recurrence score. The 16 to 20 is further divided into the patients who have high risk and low risk. So remember the number of 16 to 20 and then apply your clinical pathological features. If they are low risk, spare them chemotherapy. If they are high risk, according to your assessment, then give them chemotherapy. Now, the other thing that we discuss all the time is that the benefit of the chemotherapy in our premenopausal women, is it because of the direct cytotoxic effect of the chemotherapy, or it is by virtue of causing the ovarian function suppression or ablation? So this was a 15 years follow-up on the data of ovarian ablation versus ovarian suppression was presented by the early breast cancer trialist group. And what it shows is that women who are premenopausal and have ovarian ablation, they have a flattening of the curve where compared to the ones who have ovarian functions ablation. So in the young premenopausal women, where you think that the risk of recurrence is very high, ovarian ablation may be superior to that of ovarian suppression, which can be anywhere from 2 to 5 years of LHRH agonist therapy. And again, supporting the data of ovarian suppression is from the ABCSG, text, soft, and the HOBO trial, which analyzed 730 patients from 4 randomized studies, and it showed that there is a benefit in terms of distance recurrence-free survival, no benefit in the overall survival by giving ovarian suppression along with an aromatase inhibitors if your patients can tolerate it. Now, the other important thing that was brought on by Kevin Kalinske in this RX Ponder study was selection of patients for chemotherapy based on the RX Ponder trial. He's found that the patients who have a low AMH score, the anti-Mullerian hormone of less than 10, are the women who, despite of having menstrual cycles, are the ones who have low benefit from chemotherapy. So what we have started doing in our practice is that in the older premenopausal women, we've started doing AMH levels and seeing if these are very low, despite of they having the regular cycles, then these patients can be spared chemotherapy and be given hormonal therapy alone. The NCCN guidelines recommends both 21-gene assay and the for use as a category 1 in the consensus for both prediction and prognosis of early breast cancer. How about can we do without chemotherapy in patients who are young and who have a score of less than 20? So we were looking at, in the busy table, we were looking at the patients who were 16 to 20, and these were the patients where we were using our clinical pathological features along with the recurrence score. So there is a trial by the name of the offset trial, BR009, in which patients who are premenopausal, who are node negative, who have a recurrence score of 16 to 20, and we think they are high risk, or who have a recurrence score of 20 to 21 and who are node positive, they are stratified and randomized to two groups with chemotherapy and ovarian function suppression with AI or ovarian function suppression. There are about 130 patients who are accrued on this trial, and it's going to take about 11 years to complete its accrual and for it to have its readout. What is the duration of therapy? So is it 5 years sufficient, 7 years, or do we need to give 10 years of therapy? We know that 50% of the recurrences that we see in our patients are beyond 5 years. So what is it? How do we improve our understanding about preventing these kind of long and delayed recurrences? Now, can we better estimate the residual risk of recurrence at 5 years? And for that, we have a risk calculator, which basically you go online and put the tumor size, the tumor grade, the age of the patient, and the number of lymph nodes, and it gives you a score. And it also gives you a very easy way to calculate and justify, endorse your beyond 5 years of treatment. The breast cancer index, which is basically a ratio of H and I, measures the sensitivity of endocrine therapy sensitivity. So there are 4 studies which have analyzed prospectively the utility of the breast cancer index in these patients. And the patients who have a high BCI score, two-thirds to on more patients, they benefit from extended adjuvant therapy. The ASCO guidelines also recommends that you do not offer it to patients who are node negative and who have low-risk disease. To extend therapy to patients who are not node positive, do not give more than 10 years of therapy. And the benefit of continuing beyond 5 years is also because it prevents contralateral breast recurrences. So if somebody's had bilateral mastectomy, is in the intermediate risk group, then one can justify only 5 years of therapy. So we've so far talked about de-escalation of therapy. Do we need to escalate therapy? And the reason we need to escalate therapy is because tumor can stay dormant and the tumors can start growing and multiplying under various immune signals. Everybody's aware and most talked about is the Monarchy trial, in which patients who are high-risk disease were randomized to abemaciclib for 2 years along with AI therapy versus AI alone. And we have a 5-year data available now in terms of the invasive disease-free survival. The patients completed the treatment at 2 years, but they continue to have a separation of the graph so that at 5 years, it's almost a delta of 7.6 for improvement in the outcome. Even with dose reduction, you see that the patients continue to benefit. Nobody's able to take 150 BID. I decrease the dose to 150. It's the adherence to endocrine therapy which is really important. So how about patients who are stage 2 and 3, stage 2 disease? The stage 2 disease are also high-risk disease based on their clinical pathological features and the recurrence score. So the Natalie trial looked at giving ribociclib at a lower dose of 400 milligram instead of the 600 we do in MBC, and the patients were treated for 3 years. And the most of the patients have completed now treatment. There was a 20% dropout. And we see from the ESMO this year that there is a separation again of the graph with a 5% increment in the IDFS in the patients, both in node positive and node negative disease, in despite of dose reductions. How about adjuvant PARP inhibitors? So we were giving PARP inhibitors to patients who were triple negative, and later they were amended to include patients who were node positive as well, those who were high-risk node positive by virtue of nodal involvement, and also by virtue of having extensive residual disease calculated by the CPS EG score. And what was seen is there is a hazard ratio of 0.5 in these patients with an improvement in outcome with giving olaparib for 1 year in these patients. So to conclude, Hormone receptor positive early breast cancer, adjuvant therapy should be tailored according to the clinical pathological and genomic analysis in order to avoid overtreatment and chemotherapy. To provide the optimum duration of hormonal therapy based on the risk factors that we discuss, ovarian function suppression in patients who are high risk and young individuals, escalate therapy in patients where it's indicated. As far as the residual disease is concerned, it should be addressed with the appropriate drugs in patients who have BRCA1 mutations, and genetic testing should be done for most of the patients, especially the young, less than 50 years of age and less than 60 years of age if they're triple negative, so that will influence your decision making in adjuvant therapy. Thank you very much.